So Jason, since you're on that topic, do the hazard ratios, meaning the reduction in the risk of recurrence, impress you enough so that you think that universally we should be using either Dabtrem or Pembro or Nivo as adjuvant therapy for resected stage 3 disease? Keeping in mind what you just said, there's a pretty big distribution of risk. An early 3A, a 1.2 millimeter non-ulcerated primary with 1 millimeter or less of disease in one node is a 3A. And there are other 3As with a much bigger risk of relapse. But who are you going to treat, and what's your minimum requirement for a hazard ratio to convince you to embark on adjuvant therapy?
So this is a very interesting question that comes at a time of a lot of things shifting in our field. And so for me, I am quite impressed by the hazard ratios, both for targeted therapy and for immunotherapy. So my answer broadly is I lean towards treatment. The question becomes, in my mind, are there stage 3 patients that we shouldn't be treating with adjuvant therapy? And exactly to your point, we have to put this in the context of the recent changes to our surgical practices, which we're not doing completion lymph node dissections in the majority of patients now. So we end up not really knowing whether or not they were actually 3B, 3C. So in my practice, everybody is 3A, but obviously they are not. So how do you differentiate that? And in our practice, we're fortunate to have a multidisciplinary team where we actually review the pathology and actually look at what's going on in the sentinel lymph node that was positive. That sometimes can inform us. Sometimes features within the tumor can inform us. But I have to say that broadly speaking, my default is to treat most patients who come in who are 3A and haven't had a completion lymph node dissection. And I think that that's something also a conversation with the patient, to be able to tell them that we may or may not have very specific data for this, but given the broad environment, that would be the recommendation I would make to most patients.
So I would agree with you there. And for a time, I didn't quite know where to go with my 3As, but the 054 data clearly looks at the 3As and shows a significant hazard ratio for them. That makes me feel more confident in speaking to the 3As and offering them adjuvant therapy.
No, and so from a surgical perspective also, I think that I agree with both of you in that if we don't do a completion lymph node dissection, if we look at the studies that we've done, well, the MSLT2 study and the DCOG study, we know that there are about 25% of patients, maybe even more if they had thicker tumors and more disease in that central lymph node, that will have additional lymph nodes with melanoma in them. So I think that we know that there's a patient population that clearly has disease that has not been taken out. So I think that even more strengthens the reason for us to treat these patients. An additional thing we need to remember as well is that all of these studies were done according to the AJC 7th edition. Now that has changed. Now we have the 8th edition. And really the way I look at this, the old stage 3A is now sort of the new stage 3A and 3B. And I think that sort of splits that patient population as well, is that we now have the new 3As that are the thinner tumors, less than 2 millimeters, one sentinel lymph node positivity with a small amount of disease in it. And the question there really becomes, do those patients benefit from this treatment?
And is it appropriate to give someone with a 10 or a 15% risk of relapse and a minimal risk of death from disease over 5 years? Should those patients be given adjuvant therapy? Because as the risk drops, the number of patients you're treating to benefit one goes from well over 4, it might be 8 or 10. And that's a tough question, but well, you tell me.
So I think that from that perspective is that the common patient that we often see is a patient that has just a few cells in that sentinel lymph node that has disease in it. In general, we tend to observe those patients. But I think ultimately it is a discussion with the patient and talk about the risks and the benefits here. And it's also discussions amongst the team as well. And I would even say a cost discussion as well. Is it worth it now? I think what we don't know yet is the whole question about treating now versus treating later. And I think that the Keynote 054 data was a crossover study. The patients who were on the placebo arm, when they recurred, they were able to get pembrolizumab. And we don't have that data yet. And I think that's going to be important for us to see if sort of the true difference between treating now versus treating later.
And we will get some of that data about AJCC 8 when the 915 adjuvant trial matures and some of that data is presented. That was based on no need for sentinel node as completion nodal dissection, just sentinel node, and it was randomized between single agent versus combination. So we'll get some answers coming.